Zach Szlendak has been a research staff member for the Institute for Defense Analysis in the Cost Analysis and Research Division since 2020. Zach's recent work includes causal inference of COVID policy, research on mental health, identifying factors that affect the financial well-being of service members, evaluating alternative market mechanisms, and participating in interviews aimed at increasing diversity, equity, and inclusion. Prior to his work at IDA, Zach earned his PhD in economics at the University of Colorado Boulder and his BS from the Colorado School of Mines in Applied Mathematics.
Okay, I will get started. As the introduction mentioned, I am looking at the mental health effects of local COVID-19 cases prior to the mass availability of vaccines. I'm specifically looking in the US. Just for the motivation for this, future responses to pandemics should take into consideration mental health effects. Social isolation and loneliness leads to greater mortality. Social isolation leads to increases in heart disease and stroke, and it just makes people unhappy. And then prior to the vaccine or other treatments in future pandemics, stressors are going to be much, much larger than they will be after potential treatments. And this means that anxiety and depression will be much higher. And so if we're looking at from a policy perspective, we have people that are anxious, depressed, they're going to have reduced job performance, greater turnover. If you're looking at healthcare costs, you're going to have weight gain. I personally gained the COVID-19, and I'm sure others did as well. And then you also have extreme examples with deaths of despair, such as drug overdoses, which we saw a drastic increase in 2020, and deaths from alcohol-related diseases, which we saw an increase as well. So specifically, my question is, how do local COVID-19 case counts, which I'm looking local at the state level, affect mental health outcomes prior to the mass availability of vaccines? And then I want to look at how this effect varies by different populations of interest, because there's reasons to believe that these different populations of interest might have different effects. And so I did kind of hit at these stressors that people have. Another big one is just the economic instability. When society shuts down voluntarily or due to policy mandates, people are going to lose sources of income, and this creates mental health challenges. And then with COVID-19 or with future pandemics, other diseases, you have the fear of yourself catching it, you have the fear of others catching it, and then for the fortunate people that do get it, you have the effects on yourself and your loved ones that can lead to stress and depression. But from our four populations of interest, I kind of want to address why I think, or why we might think that they could have different effects. So of the US population, this is going to be our baseline effect. And then there's military families. So military families probably have less economic instability due to pandemic shutdowns because you got great job security with a military paycheck. However, you might have more fear about COVID exposure for yourself or others because a lot of jobs don't allow you to social distance as much as others. As soon as COVID happened, I just was able to stay home and work on Zoom, but not everyone is that case. And so with some mission critical jobs, you can't social distance, which then increases that fear of COVID exposure. Then there's TRICARE and Mhs Beneficiaries. These people, have a lot of military families in them, so those aforementioned effects could be there. But they also have, good health systems. So in the US, a lot of people don't have good healthcare and other effects, or health insurance and other support systems. So then that could amplify stressors where not only are you worried about, the direct effect of getting COVID, but 6 months, 3 months down the line after getting it, you're going to still have those bills that you may not be able to pay. Also with Mhs and TRICARE beneficiaries, you do have a lot of veterans, and so they may be more trained and more capable of dealing with high stress situations, which could lessen the impact of the social isolation and other things. And then finally, we have VA beneficiaries. With VA beneficiaries, you have an older population often that tends to have more pre-existing health conditions. And so there's a very good chance that they are more concerned about exposure than others. but as I mentioned before, they do have good supportive, healthcare system, championing them along. Okay, so the first thing I want to do is kind of talk about how I'm measuring mental health. We could send out, flyers with people and just have them draw a smiley face, a frowny face, something in between. What we do is we use the Phq4 Questionnaire. I really want to emphasize this, seems like something that's you just fill it out to kind of self-report how you're feeling, but this is a clinical diagnostic tool. And what we do is we have 4 different questions getting at anxiety and depressive symptoms. We add them up together, and then low score means you have less of a concern about mental health, and then a high score, you have more psychological distress. And so the score ranges from 0 to 12. Most of the time you see people kind of on that left part of the distribution. It's a distribution that's skewed to the right because a lot of people are fortunate enough to not have any psychological distress. So with this figure, there's a lot going on. I don't want you to try to focus on everything. The first thing let's focus on is kind of just the general shape. Don't look within numbers, but just look at, more people are to the left. There are some people to the right. So it means that more people have, mild psychological distress. There are some people with severe distress, and we especially see that a lot of people relative to, the numbers next to it report 12, which is everything is bad. The other thing I want to, then focus on now is kind of the within number differences. So we can see the key at the bottom. We have the general U.S. population, likely military families, TRICARE and Mhs beneficiaries, and VA beneficiaries. So if we look at the 0, we see that the U.S. population has a lot fewer respondents reporting 0 than the other populations of interest. This means that the other populations of interest self-report better mental health status than the general U.S. population. But if we go all the way up to 12, the extreme situations, you do still see a lot of people for populations of interest reporting psychological distress, extreme psychological distress. And so for our analysis, you already can guess that I have some sort of data on Phq4 scores. So that comes from the Census Pulse survey, which was a survey sent out during the COVID pandemic, cast a wide net, had a lot of respondents. And I want to point out that this survey, though, was cross-sectional. So everyone only was polled once, and then they'll get a new, casting of the net, get a new set of people. We combine this data with, IPUM's data to get prior demographic and other things at the state level. We have COVID case counts. We have mobility data. We have weather data. And we combined this all into a single data set to kind of look at, well, in this case, the effects of COVID-19 on mental health outcomes, but we were able to look at other questions as well. If anyone wants this data set, please feel free to shoot me an email or shoot Emily an email. Our email address is at the bottom, and we can provide you the data set. Now, with the Pulse survey, I do want to kind of caveat for populations of interest, they later added a question to identify military households. But early on in the pandemic, because it was a new survey that they're just trying to get going, which the fact that they got it turned around so quickly was great, they didn't have the identifying variable. So what we did is we created a proxy. We looked at people that are TRICARE or Mhs beneficiaries. We looked at people under 50 and people that weren't VA beneficiaries. I know there's people over 50 that are military households. I know that there's people that are VA beneficiaries in military households. But we thought that this kind of fuzzy approximation would give us good accuracy and allow us to capture a large share of military families. There are ways where we can improve this accuracy, but if we do that, then we ignore populations that we care about. So if you had a gender restrictions that we're going to focus more on men, you could get that accuracy a little bit, but we were not willing to exclude the populations that should be examined as well. Okay, and now for our methodology. As an economist, I wanted to find a clever instrument to get pseudo-random variation and case counts to kind of look at that effect. We played around with them. But the problem is just with COVID, there was so much going on, so much chaos that you couldn't, find an exact A causes, a random outbreak in case counts that we're going to use to identify things. So what we decided is we want to do an ordinary squares specification. We have lots of alternative robustness checks to kind of check how valid this is. But with it, I really want to point out that our identifying variation comes from changes in cases at the state level for the second half of 2020. So the pulse survey spanned that second half of 2020. We want to cut off 2021 because that's when vaccines became widely available. We do have a specification that goes until February, and we see similar effects. Sorry. But again, you have very different stressors pre-vaccine and after vaccines, and there's already existing literature that looks at the effects of vaccines on mental health. Spoiler, they're great. They reduce stress. Get vaccinated. Another thing we did is with the specification, we controlled for time constant differences at the state level. So it could be some states are more likely to report depressive symptoms. I love Annie Hall. Woody Allen made some great movies. I'm going to stereotype New Yorkers as people that are very willing to report depressive symptoms. They also had a lot more cases. So we wanted to make sure that this wasn't driving variation, and we kind of just purged all the data of the time constant state level effects. One second. Yeah. And then on top of that, we control for policies at the state level, individual, socioeconomic, and demographic controls. I do want to point out that we exclude job loss because that can be an effect of local COVID outbreaks. This is a tough thing because it could be an effect of lack of demand in Kentucky leads people in Ohio to lose their jobs. But we thought it would be safe to exclude job loss because there are definitely effects where we have a local outbreak, restaurants shut down, people can't work, and there's that. We include weather conditions and a time trend. Okay, for the results, so the big thing in this red box is you can see that all four populations have worsened mental health as local population or local case counts increase. You can see that they are pretty similar in size, with the possibility of likely military households having a much larger effect. Now, I'm going to switch these slides quickly to kind of scale this, because this is the effect per new case. And these also numbers are hard to interpret. So I want to kind of step back and say what's going on. In the late part of 2020, our respondents saw new cases per day, much lower than what we saw later with Omicron. The DC area had 300 new cases per day per 100,000 people at one point. So in the later half of 2020, this is kind of the distribution that respondents were living under. And then I want to scale our results to that to kind of make them more interpretable. So let's say there's 50 new cases per 100,000 people in a state. So how to interpret that is for the general population, there's about a 0.3 increase in the average Phq4 score in that state. Another way you could think about it is, this would be the same number as 3 out of 10 people having their Phq4 score increased by 1, and the other 7 having it not affected. You see that with the likely military households, they have a larger point estimate, but it's fairly imprecise, so we can't say if it's definitively different than the US. But it is possible that they did have a larger effect, just because, as I mentioned before, they weren't able to social distance as much as others. Now, these effects seem small on a 12-point scale, but I think it's really important to remember that every single person in the state is treated in terms of local cases. With a lot of policy interventions looking at mental health, a small fraction of the population is treated. A small fraction of the population experiences the traumatic event that leads to mental health problems. And so the number of people that have mental health problems can be relatively small. with COVID-19, even if you don't catch it, you have those economic stressors. You have that fear of catching it, the fear of the loved one catching it, stuff like that. So even if the average isn't huge, there's going to be a lot of people that do have very large effects, which is going to mean that there's going to be a public mental health crisis. Okay. And one thing I also want to point out is, any mental health change, we also have to look at what's the baseline. Going from, perfect mental health to a little bit of a worsening is bad, but it may not be as dangerous or much of a mental, a crisis as going from bad to worse, right? It's not a linear effect. So one thing I want to do is kind of look at the baseline. And you can see that the US has a higher baseline than likely military households, Tricare beneficiaries, and VA beneficiaries. However, there's one thing that we notice in the data is that young people are very anxious. They're much more likely to be depressed, and we thought this could be biasing things. So what we did is we purged all the data of things related by age and said, okay, well, if there's no age variation, what does the new average Phq4 score look like? And here you can see that likely military households actually had a great baseline level, and that VA beneficiaries actually had a worse baseline level than the general population. They just, prior to that, had a reported lower level due to being healthier or being older. So this is, something we should have in the back of our minds, where you are, especially with these likely military households, negatively affected, but you had a better starting point. So hopefully there'll be fewer extreme instances than if you had a starting point equal to the general population. And then I'll be quick here because I'm almost out of time. But as I mentioned, we couldn't find really clever pseudo-random variation. We tried variation due to policies, but then there's potential biases that would create. So we thought we would just do OS and then just have a law of robustness check to make sure that things are stable. So instead of using state fixed effects, we used state level controls. We did alternative time trends. I mentioned the political controls. We excluded New York and New Jersey due to extreme underreporting. And with all those cases, we see pretty much the exact same effects. Now, there's a couple changes where we see similar effects, but slightly attenuated towards zero. So one, if we include for individual time variant economic controls, this is mainly job loss and those economic hardships. The reason we excluded these controls from our main sample is part of the COVID effect of local cases can act through that mechanism. So it makes sense that part of this mechanism disappears, we see attenuated results. And then also another thing we did is assume that survey respondents are confused. They are unsure whether several days or more than half the days is greater. And they don't just do a 0, 1, 2, 3 scale. And even if they're confused like that, we see very similar results, just slightly attenuated, which makes sense because we're reducing our data variation when used that. I do want to point out that there's a couple things that could bias things that we could not address. So one is just possible lower propensity to report mental health symptoms for different populations. Maybe military households are more stoic. They're more likely to say that things are great when they're not. If this is the case, then their results will be artificially attenuated towards zero. In reality, they should be larger. If this is true, then this effect right here likely would be statistically significant, statistically different from the US population number, which would be a big concern. Another one is the underreporting of COVID-19 cases. So maybe it might be wiser to either scale our results based on the rate of underreporting, or just think of our results of our estimate as per local reported COVID case instead of true cases. But I do want to really emphasize with all these biases that just lower them a little bit towards zero, or in the case of the military one, expand it a little bit further from zero, and they don't eliminate the effects we found. So just in conclusion, to try kind of give it policy perspective and insight into the next outbreak. Mental health is definitely worsened by local outbreaks. However, the risk of infection should not be ignored to treat mental health. So I'm not saying that during an outbreak we should have everyone still going to see mental health providers in person, because that could create a lot of cost that isn't worth the benefit of treatment. But something that all providers should do is say, hey, there's a local outbreak. Do I need to have more virtual appointments, supplement things along those lines? And then also I want to really hit that although my effects aren't, everyone is going from not depressed to very depressed, every single person in the state is affected by these local case counts. And so even if, the average effect is small, there's going to be a very, millions of people that have a very large effect. And so it really is a mental health crisis. So I think that should be about 2:20. Does anyone have any questions? Okay. Well, if there's no questions, I'll stop sharing and should be able to finish on time. Thank you.